So thank you for joining us. This is Dr. Olcay Aksoy. I'm one of the interventional cardiology attendings at University of California, Los Angeles campus. Today we'll talk about aortic stenosis and its treatment as it's progressing over the years. And there has been much change in this field in the past couple of years, in case you have been following. And new things have been happening almost daily, on a daily basis. So I wanted to give an update on what's new, what's coming up as outcomes and treatment options actually improve on almost on a daily basis. So we'll talk about this today. And if you have any questions, this is kind of open to the web. So please feel free to put in any questions on the hashtag UCLAMDChat, and we'll get to them at the end of the talk. Okay? So I have no relevant financial relationship to any of the companies, so there's nothing to talk about there. So basically on this presentation we'll talk about what aortic stenosis is, what causes the problem, what are the symptoms to look out for, and what the prognosis is if you treat it or don't treat it, really. And what the medical options are, really. So you can do medications, what happens with that. You can do open heart surgery, and we'll talk about some of that. And also we'll talk about this final kind of last piece of this, which is the transcatheter aortic valve replacement. It's a procedure that's been developed in the past 1 or 2 decades almost, actually, and it's really revolutionized the way we approach this disease. Okay. So just kind of give you a background summary. This is the heart, and this is kind of a cartoon schematic, and this is the real thing. Basically what happens, heart is really, you can consider it as a bag of muscle. What happens is the used up oxygen, used up blood comes from the body back into the heart, into the right side of the heart, and goes into the lungs where you get rid of the carbon dioxide, get the fresh oxygen, and the fresh blood now comes in through the atrium, comes in through this mitral valve through here, and goes into the muscular chamber, which is called the left ventricle of the heart. Now through the aortic valve, which is here, it goes out and it gets distributed to the rest of the body. So the problem that we have here that we're going to talk about is the aortic stenosis. So if we go back, the aortic valve is situated here, and that's really the connection that connects the heart, the left ventricle, the muscular part of the heart, to the rest of the body. And aortic stenosis is, what it is that normally this valve has 3 leaflets, and these leaflets, 1, 2, 3 here, they need to be thin, pliable, and really it should be opening and closing in a nice fashion with every heartbeat. What happens in aortic stenosis, and stenosis just really means narrowing, is that you get over time, you get accumulation of what you're seeing here, which is this calcium nodules, a thickening of these leaflets, and really you get an impedance to flow, and these leaflets will not open and close properly. And as a result of that, the heart is going to have a tough time, the blood is going to have a tough time getting out of the heart, and as a result, people get symptoms, which we'll get to. So this is these are some images that we had at UCLA from some of our patients. This is a still frame of the echocardiogram. This is a movie that you're seeing the valve here, that all 3 leaflets are opening and closing properly. It's a nice opening, and the blood ejects out of the heart as expected and gets distributed to the rest of the body. What you get in aortic stenosis, and this is again another movie here, the aortic valve is situated here. You can see that it doesn't really move much, it doesn't really open as properly, and you can see the same thing here. You can see a lot of thickening here, you see a lot of calcific nodules that we see here, and you can see that the opening really is almost a pinhole here. So as a result, the blood is not going to be able to get out of the heart, and it can back up into your left atrium through this mitral valve, and then it can back up into your lungs. As a result, you get short of breath, you can get chest pains, and you can get dizziness and lightheadedness. And this is what really aortic stenosis is. How often do we see it? Well, it's estimated that it's prevalent in almost up to 7% of the entire population in patients who are over the age of 65. It's more likely to affect men than women, and 80% of the adults with symptomatic aortic stenosis are in fact male. So this is actually a relatively common problem to have in the elderly population. And what causes the aortic stenosis? Well, the most common thing is age-related, really, we think. Although it's not a passive process, it's just age-related, it's just that it's not just a wear and tear phenomenon, it's inflammation that then begets more inflammation. As a result, you get thickening, scar type of tissue formation almost, and then you get calcification of these leaflets, and that then really cause rustiness, so to speak, of this valve, this outside door opening to the outside world. and the door doesn't open and close properly, and that's what aortic stenosis is. Other things sometimes that we see that are less common are infection. Sometimes we see rheumatic fever, so this is a disease infection that people get as really in earlier ages, and over 20, 30 years time, then you can get valvular disease associated with that. You can get stenosis as well as leakage back from the valve as well. And some people are actually born with congenital anomalies, which we're not going to get into too much. But if somebody is born with what's called a bicuspid aortic valve, meaning they have 2 leaflets of the valve as opposed to 3, then we sometimes see that patients at the age of 40s and 50s can get into aortic stenosis type problems. And why does it occur? So we kind of touched on this. It's age-related calcific aortic stenosis is the most common cause, and as prevalence steadily increases with age. And it's really associated with inflammation of the valve that leads to progressive calcification. Initially, it's along these flexion lines here, and then at the bases, and then leads to immobilization of one or more of the aortic cusps, leading to a left ventricular outflow obstruction. That just means that the blood cannot get out of the heart as properly to the rest of the body, and then it causes symptoms. And then what are the symptoms? And those would be 3 really cardinal things that we think about really are angina, so that would be a sensation of aching, burning, discomfort, fullness, pain, really squeezing pressure in the chest. That's the chest pain that we usually talk about with heart attacks, so this can give you similar type of chest pain to a heart attack. You can get dizziness, so that's the syncope part. That just means that you're having dizziness and lightheadedness, and it can sometimes lead to syncope, so a really brief episodes of loss of consciousness even. And the follow-up to that is shortness of breath. So when you exercise, when you're walking even maybe a flight of stairs, or when you're even just walking on flat ground, maybe even block, maybe even a couple of steps, you can get short of breath. So you start feeling winded, and that could be from aortic stenosis. Again, that's because the blood cannot get out of the heart and can back up into the lungs. As a result, you can get fluid in the lungs, and then that will give you the shortness of breath. Other things that we see commonly are, again, dizziness we talked about. A rapid irregular heartbeat is a common thing that we see. And also palpitation is another, again, sign of rapid irregular heartbeat that we can see as well. So what are the risk factors that we have found over the years and with research? It's increasing age. It's the male gender. We've touched on these. Other risk factors are hypertension, so high blood pressure. Smoking is a risk factor. Some elevated cholesterol is a risk factor. And lipoprotein A, which is another cholesterol type protein that's seen in the blood, is also a risk factor as well. So then we talked about what aortic stenosis is and how what causes it. So what are some treatment options? Well, number one thing that we would always think about is medications. Do we have any medication to prevent this? And even when you have it, can you take a medicine that will keep from getting worse? So unfortunately, multiple medications have been tried in this matter. And even though cholesterol statins have been tried, in the beginning there was one study that showed some benefit to it. However, subsequent studies didn't really show that this is slowing the progression of aortic stenosis. So that's kind of didn't work out. So then ACE inhibitors, these are some blood pressure medications that looked at the thought process, so they can suppress maybe the inflammation of the valve. And that didn't really pan out to be the case, although we don't really have large studies to really answer that question. And bisphosphonates is something that we've been a part of and studied this, and it also has not panned out to be of any use really in prevention of this disease. Even though I have to say there's a lot of open field to study this, there's a lot of open room in this and a lot of research ongoing to see if we can prevent the progression of AS. And hopefully in the next several years and decades something will come up really, but there are really ongoing studies, and UCLA we are part of many of these studies as well. And hopefully we'll have some more good news down the line, but so far we cannot really have any recommendations to say that one medication will be actually useful. How do you diagnose this disease? Well, it starts with the office visit really, with a stethoscope. So somebody listens to your heart and you hear a loud murmur, and that usually triggers an echocardiogram, which is what you're seeing here. So you get a jelly on the chest and you get an ultrasound with that probe, and we can visualize the valves of the heart and the heart itself, and then a lot of times we can actually confidently say that this is what you have. So aortic stenosis is most commonly diagnosed this way. And again, we talked about the murmur. It's a audible systolic heart murmur that you can hear on the exam. And there's this, there's soft absent second heart sound that goes along with the valve not closing with a loud sound. So it's not a crisp sound that you hear. And other things that you find on exam are delayed carotid upstrokes. That just means that the blood is not getting out of the heart as rapidly. So then you have a delayed upstroke in the carotid up to the neck. So these are some things that we look for. But in general, if you want to look at the entire spectrum of how you diagnose aortic stenosis, again, it starts out with the auscultation. The chest x-ray can be of some use. Electrocardiogram can show thickening of the heart muscle. This is the echocardiogram, and ultimately you can get a cardiac catheterization, which remains the gold standard, although echocardiogram is really the most common modality of testing that's used for testing, finding out if you have severe aortic stenosis. And how do we grade aortic stenosis? Well, there are some guidelines. Unfortunately, this is a fairly common disease, so we have fairly well-defined guidelines and how to kind of classify these disease presentations. So on an echocardiogram, for the most part, what we look at is jet velocity, so how fast the blood is flowing across that valve. So if it's more than 4 meters per second, what the mean gradient across that valve is more than 40 millimeters of mercury. If your valve area is less than 1 centimeter squared, that's also consistent with severe aortic stenosis, and also valve area index that just kind of normalizes the valve area to body size really. And if it's less than 0.6, then we say that you have aortic stenosis. And that the classification actually makes a huge difference, because if somebody is classified as having a severe aortic stenosis, then really we think about how we should treat the patient next. And why do we need to treat the patient next? Well, this is a graph that was published in the 1960s, in fact, and this is what's showing us the kind of natural course of aortic stenosis if you don't really do any treatment, which we'll get to in a second. But basically, this was published in the 1960s because at that point there were no surgical options, and these people were monitored closely. And even after monitoring closely, unfortunately, this is kind of life expectancy. You get onset of severe symptoms, and unfortunately, you don't make it past a couple of years. So if you're coming in with predominant symptom of angina, that would be chest pain, your expected life survival is about 5 years. If you have passing out spells, it's up to 3 years. And if you have heart failure, and that would be swelling in the legs, shortness of breath, cannot do the things that you want to do, then your expected survival is about 2 years only. So you're really flipping a coin on your life at 50% at 2 years if you have shortness of breath and aortic stenosis without treatment. And this is a graph that's actually a very sobering kind of a graph. It's in patients who have inoperable aortic stenosis, meaning they're not really candidates for surgery. If they don't get the surgery, and this is what the expected outcome is only 3% of the patients will be alive at 5 years. So that means 97% mortality at 5 years in patients who are not getting surgery. And compare that with the cancers, really. You have breast cancer, 20%. You have colorectal, 12%. You have prostate, 30%. Ovarian cancer, 28%. 5-year survivals. I mean, this is pretty dramatic. The good thing about it is that we have treatment options that are beyond surgery at this point as well. So this doesn't need to be 3% anymore. Another graph that was looked at, this is again many years ago, that the survival is worse in the elderly. So they looked at patients who are over the age of 80, and then they looked to see what their survival was, and they found out that you're really also flipping a coin at 1 year, 50% survival at 1 year if you're on the elderly side. And control group is kind of same age patient population with no aortic stenosis. So this is a serious problem to have, and thankfully that is something that we can fix. And what is the fix? Well, the original studies were done with the surgical approach. And if you look at this is kind of a complicated graph, but if you have symptoms and you don't get surgery, this is your expected survival over the years. If you have symptoms and you get surgery, then this is your expected survival up here. And it's pretty dramatic increase in survival. You can just imagine how many years you're adding to a patient's life by doing the surgery. So it's pretty impressive outcome with surgery, and surgery is great in this sense. So what are the recommendations? So according to the American Heart Association and American College of Cardiology guidelines for valvular heart disease, aortic valve replacement is indicated in virtually all symptomatic patients who have severe aortic stenosis, and that's class 1 recommendation level of evidence A. What that means is very highly recommended, and the evidence that we have is excellent for this. So it's highly recommended that if you have aortic stenosis and symptoms, that you should really get this fixed. And how is the surgery done? Well, surgery is, for the most part, it's done through median sternotomy, which is here. The sternum is the bone in the center there. The surgeon really kind of opens that up. And then so there are some other approaches that can be minimally invasive robotic surgery that can be done this way as well. But ultimately, what you're getting is either this valve or that valve. So this is a mechanical valve that you're seeing. So if you get the mechanical valve, you're going to end up on Coumadin the rest of your life. That's a blood thinner, which is associated with some bleeding complications down the line. So we usually reserve this type of valve for young patients. And this is a bioprosthetic valve, meaning this is made out of either cow or pig tissue, and this is sutured in place. And once it's in, its expected lifetime, how long it's going to last, is about 14, 15 years in this day and age, in the most modern setting. So what does it look like in real life? This is actually one of my patients that I sent for surgery, and this is what it looked like in the operating room. Here's the valve. That's really, you can see the thickening of that. It's really destroyed, and it wasn't really doing much. Unfortunately, this patient was in really bad shape at that time. They cut out the old pieces out. Again, this is open heart surgery. And they put a new valve in. You can see the nice kind of appearing, crisp appearing thin leaflets, and that's going to open and close with every heartbeat. So then he's had the surgery, and he's doing great right now. And we kind of joke about how everything went through, and he's doing great, and he's back to running his, going back to work and running really almost on a daily basis. So he's doing great. So surgery is a great option. Problem is, not all patients with aortic stenosis are able to get surgery. And why is that? Well, because surgery is not the most benign procedure to have, so it can have, people can have tough time recovering. Again, we're talking about patients who are on the kind of more elderly side who have this problem. So they're not necessarily the best candidates for open heart surgery, and which is very understandable. So people have looked at this, and in the literature, if you look back, almost up to 40% of aortic stenosis patients do not really get recommended surgery because of their overall situation, their overall condition. So because of this, 40% of the patients are not really treated with this potential life-saving procedure. And we're back to that graph that we saw that you have 2 years left in your life, and it's kind of we're left in that situation. And that's how it was up until a couple of years ago, actually. Again, this was also studied in Europe, and they looked at the same thing, and they found that 33% of all elderly patients with severe AS were denied surgery by their doctors because they were just not candidates. Well, why is that? Because many elderly patients will also refuse surgery because they perceive themselves to be too old for open heart surgery. But having said that, age is not really a contraindication. So if you look at the guidelines, if you have more than a few years of expected life expectancy, then surgery may be something that will add more years to your life, and so you can spend more time with the loved ones. So this is something that we can actually recommend to some of our patients. So we actually did a TAVR patient recently, which I'll get to. And he was actually 96 years old, and he's still kicking, having a good time. We were pacing each other the other day, and he was actually going faster than I was. So age is a number, really. It's actually true. Some 90-year-olds look like they're 60, and they function like they're 60. And unfortunately, there are some 60-year-olds they look a little bit older. So the age is not an issue. It's really the condition of the patient that we look at, really, for the most part. So just because somebody's on the older side, we don't think that we should just kind of leave them alone. I think in this day and age, especially when we have a lot of treatment options. So I labeled this talk as Future is Here, and what does that mean? So transcatheter aortic valve replacement has risen as a promising alternative to surgery in those 30-40% of the patients that are not being offered surgery. And we're really getting very good outcomes. And now, even better, we're now using newer generation valves, which are safer. Procedure is easier, people are going home quicker, and outcomes are actually better. And I'll get to that next. So what's TAVR? So for patients who are at either high risk or too sick for open heart surgery, this is an alternative. I'll show some videos of this thing. So basically, you're putting the valve in a position where instead of cutting out the old valve with open heart surgery, you're putting a new valve over the old valve. And this was first published in France, actually, by Dr. Corbier in 2002. And ever since then, it's really taken off to be one of the most revolutionary treatments in cardiology and really in medicine in general. So these are in the US, there are two valves that are currently approved. This is the SAPIEN 3. This is a balloon expandable valve, so it's basically a metal cage. Inside of it, there's a valve. And this is the Evolute R. This is from another company. This is a nitinol frame, so it's kind of a self-expanding frame that opens up, and then the valve starts functioning. This is made out of cow tissue. This is made out of pig tissue, ultimately sutured inside. And over the years, things have improved. So these are the first generation, first ever valve placed. It's on the left side here, 2002. Now we're 2013. This was the newest generation. This is now what we're using now. This was approved only a couple of months ago. One of the good things about it is that we used to use from groin access this big catheter, 24 French is how we measure these things. Now we're almost half of that size now, so a lot of more patients can be able to can get these valves done through their groin actually, as opposed to it used to be almost 50-50 a couple of years ago, and now we're doing maybe 90% from the femoral groin approach and maybe 10% from the side of the chest, which I'll get to. And ultimately, this is how it's done. You're going to have the wire catheter come around. Here's the valve. We inflate the balloon, which I'll show you again. And then the valve sits in place, and the valve opens and closes, and now you have almost like a new door, really, so to speak, that's letting the blood go out of the heart. So this is how the procedure is done. This will go through kind of how we think about it and what we do. So this is the valve that's really, you can see, thickened and calcified, and there's all these thickenings over it, so it's not really opening and closing properly. So if the procedure is done from the groin approach, which is which is what's shown here, we put a wire up, and the wire goes around, and then we cross this valve, go into the heart, and after that wire is situated in a safe fashion, we go up with a balloon, and then we're going to make some space with that balloon for the heart. To be able to keep everything stable, we pace the heart to be faster, to almost create a standstill for maybe about 5 seconds. So now we have more room in the valve. So we can now put in our crimped valve at this point. And that valve, so this is just the sheath going in, and that valve has a balloon inside of it, and it's the metal cages around it, which is this one over here. It goes up and over. So here we're kind of assembling the device in the aorta. And then once it's all assembled, it will go up and over, and then we'll get situated in a perfect position, as you will see. When we spend a lot of time deliberately to really put it at the right place, because you don't want the valve moving up or down and go anywhere that you don't want it to go. And then we pace the heart and we inflate the balloon, and you're seeing here the balloon is down and the valve is now opening and closing. And then once we're done, we check for what the outcome is like using the echocardiogram, and we look for there's any leakage around the valve or from inside the valve, and everything looks okay. There's no damage done anywhere else, which is rare anyway. We triple check everything, and then you can see the valve opening and closing, and we're happy, and we take out all our equipment and we're done. So this is essentially how it's done. This is as kind of some cases that we had done in the past. Here's a wire that we had talked about before, and this is that sheath catheter going up. The next one is, this is actually a real case where here there's a lot of traffic really. This is one of the catheters that we monitor the pressure with. This is a pacer wire that we use to pace to create maybe 5 seconds of standstill. This is a camera from looking within, and that we don't use that anymore actually, which I'll get to later. And there's a pigtail catheter that we inject contrast with, and this is the actual valve. As we pace the heart, you will see we're looking for the best position. We like the position, we inflate the balloon. Everything is looking good. We take that other catheter out and you inflate the balloon all the way, and then the balloon comes down. And this is the entire procedure really. And now the patient has a new valve essentially in place, and that aortic stenosis is fixed. So this is what the procedure is all about at the end of the day. But what is the data for this? So why are we doing all this, and why are we all excited about this? Well, so this was a study that was published. This is called a partner study that really is the initial study that changed how we think about things. So what they did is they looked at almost over 1,000 patients. This is the inoperable side, meaning the patients had no options. They are not candidates at all whatsoever. So then there was a comparison between this TAVR valve and medical management. And then the medical management side actually more frequently got balloon valvoplasties, meaning they just put the balloon up and down and didn't put a valve in. And then those were compared, so medical management and the TAVR valve. And on the other arm of the study, the high-risk patients, so patients were able to get surgery, but they were just high risk, so they compared the TAVR valve versus the high-risk patients' surgical valves, and they looked at the outcomes. So this is what it looked like at the end of the day. So this is out to 2 years. And then if you look at the survival, this is all-cause mortality. At about 1 year, in patients who were treated with standard therapy, that would be medical management, just medications alone, you have 50% mortality. And if you have the TAVR valve, you have 30% mortality. So basically, you're adding 20% of survival to those patients. On this one, at 2 years, you have 25% difference in between the two arms. So basically, you're increasing the chance of somebody's survival, by almost 25% if you do the TAVR surgery. So this is actually pretty dramatic difference, actually. And when it was compared to, this is the same study, when it was compared at 3 years to open heart surgery versus this TAVR valve, you can see that the curves essentially overlap down the line. There's no statistically significant difference. So in high-risk patient population, the open heart surgery versus TAVR was essentially had the same outcome in terms of longevity of life. And this is now true out to many years. Here's the other study. So those first two studies that I discussed was with the balloon expandable valve. So this is now the core valve that Evolut R's kind of prodigy of this Evolut R that I showed you in the beginning, that nitinol self-expanding frame. And when they compared surgery with the transcatheters with the TAVR valve, and they actually, in fact, did find that there was a survival benefit to doing the TAVR valve as opposed to the surgery, and that was about 5% at 1 year, and it was statistically significant. So that was actually interesting. Now, the one thing that we have is that not everybody has enough or big enough iliac blood vessels, so blood vessels in the groin area. So in some patients, unfortunately, we cannot go from the groin. This is becoming less of an issue with the newer generation valves, meaning that, as I showed you before, the catheters that we're using are getting smaller and smaller, so now we can really go on the groin much of the time. But in those patients who really have essentially no access from the groin, the one option is to go from the side of the chest. This is, again, you're not going on heart pump surgery, heart pump really, but you're going through the tip of the heart, and actually you end up getting the valve situated that way. And then you end up getting a small incision at the side of the chest. So, and then this is a similar procedure at the end of the day that you're getting the same valve. It's just that you have, if you have no blood vessels that are good enough to go up from the groin, this is the other alternative that we can use. There's a couple other alternatives that we have, but this is really the most predominant one. As far as how often we need to do this, well, this used to be almost 50% of the cases several years ago that we had to go from the tip of the heart. Now we're down to maybe about 10%. We're using 90% from the groin with the advent of these new techniques and new sheets and new generation valves. So what is new? Well, initial data that I just showed you with the SAPIEN valve, or that's the balloon expandable, or the core valve, which is the self-expanding valve, was with the first generation valves. They already essentially matched surgery. There are new valves now. This is a newer generation valves. These valves are better. You get better procedures. You get quicker procedures and actually safer procedures and easier procedures. And the outcomes are actually better too, because there's some design improvements to these valves now. So here's that balloon expandable valve that we talked about initially, and I showed you the videos of actually. So this is the SAPIEN 3 valve now, and they looked at the high-risk cohort and they looked at the intermediate risk cohort now. And they compared these valves, transfemoral and transapical approaches, to each other. So basically, what they looked at was average age of the patients in this study was 82. So really, again, like we said, the age is not really the issue, and there are a lot of 90-year-olds in this study as well. And majority were male, as you can see. This is the average STS score. This is something that we follow and see what the risk of surgery is. So expected surgical risk of not surviving surgery at 30 days is about 8%, 8.6%. And they were able to look at about almost 600 patients. And this is what they found, that mortality at 30 days was in fact 1.6%. Just if I go back, with surgery, it would be expected that their risk was 8.6%, but with this TAVR valve, it's 1.6%. Of that, cardiovascular death was 1%. So essentially, from the heart, you're getting 1% mortality, which is, as compared to that 8.6% mark, it's actually a pretty remarkable improvement. What is the risk of stroke? Well, this kind of deserves its own special presentation, but basically, in the first generation valves, the risk of stroke was higher on the TAVR valves as compared to open heart surgery. But as the newer generation valves came along, so now all stroke risk is down to 1.4%. It used to be almost 6%, 7% in the beginning, which I'll show you a graph of. Now it's down to 1.4%, and disabling stroke is less than 1%. So this is actually a very remarkable improvement on new generation valves as well. This is another breakdown of the strokes. Again, disabling stroke rate rate is 0.8%. So it's a very, very small risk actually. If you look at the newer generation valves, here's what we're looking at. So this is the first ever study. This is at 30 days mortality. It was 6.3% with the first study. Now we're down to, this is only 3-4 years, mind you, of improvement in new generation valve. We're down to 1.6% from 6.3% in terms of all-cause mortality at 30 days. So dramatic improvement. What about strokes? Like I mentioned, the risk of stroke with the first generation valve was about 7% in the 30 days outcomes. Now we're down to 1.4%. Of that, again, the disabling stroke was 0.8%. So again, very dramatic improvement. And that's due to new generation valve. That's due to smaller catheters that we were using. And we were actually learning to select out patients better actually as well for the risk of stroke. If you look at the other clinical events, you can have vascular complication that usually means bleeding. That's about 5%. Annular rupture, that's kind of structural damage to the heart. It's really small, so any other risk is fairly small. The one thing that comes up is the requiring a new permanent pacemaker. That's actually about 13%. So this is actually a real risk that we usually sometimes think about, especially in someone who has old and existing conduction disease. So this valve may make it worse. And the reason for that is that where we're placing the valve is just next to the wiring in the heart. So when we're putting this valve in, it can actually compress on the wiring in the heart, and it can actually cause the conduction system of the heart to get worse, and it can lead to a pacemaker. What about the periviral leak? This is something that we follow very closely. That just means that the valve was, there's some leakage of blood back into the heart from around the valve. And with this valve, it's actually that severe leak was non-existent, moderate leak was 2.5%, and mild leak was present in 30% of the patients, essentially non 60% of the patients. So it's actually pretty good. This is a lot more improved as compared to the first generation as well. So basically, key takeaways: 1.6% all-cause mortality at 1 month and 0.8% disabling stroke. It's a pretty dramatic improvement from the first valve that we had. What about the intermediate risk? So far, the patients that we've talked about have been high-risk patients. So because FDA has so far approved for us to use this valve in high-risk patients only. It's not approved for intermediate-risk patients. And that's determined by really what we think your surgical risk is, and that usually is more than 8, then we consider that to be high risk. If your numbers are between 4 and 8% in terms of survival, in terms of mortality with surgery, then you would be considered intermediate risk. So in this patient cohort that they studied also, they looked at the intermediate risk patients as well. And when they looked at the mortality at 30 days, it's 1.1%. What was expected was 5.3%. So with this TAVR valve, you're down 1.1%. You're really getting the mortality down by almost by 80% by doing this TAVR procedure, so which is kind of impressive finding in and of itself. As for if you look at the stroke side, all stroke was 2.6%, disabling stroke was 1%. So excellent numbers, especially as compared to the first generation valve that we used to have. What about the other nitinol self-expanding frame? This was also studied. Now we talked about already that this study in fact did show that this TAVR valve is actually, as far as survival, is superior to the surgical valve. It came out to be. And the surgical, in terms of the study too, if you look at the strokes, actually you get less strokes with this TAVR valve as well. So this technology is also very promising. The one problem though that they had also is that they had more implants of pacemakers. So it's almost up to 20%, 25% in this case after you place this valve in. So in somebody who has conduction disease problems, that this valve may not be the right valve for you if pacemakers is something that you don't really want to. But having said that, the other valve also needs pacemakers occasionally, so this is something, that discussion to be had with your cardiologist and your surgeon. If you look at the kind of newer generation of this valve, 1.3% all-cause mortality, that's the Evolute R, and this follow-up to the core valve that we had talked about in the beginning. And it's pretty low numbers. And if you look at the stroke, it's 3.3% stroke. So this stroke rate is a little bit higher than the other valve, the balloon expandable valve. But those are the both two options that we have. In this one, the permanent pacemaker rate is down to 13% as well. So those numbers are improved. So this is really what I wanted to talk to you about for the overall aortic stenosis and TAVR part. I just want to touch on how we've done at UCLA so far. Now this is data from up to a couple of months ago. We had done 134 at that point. And we're up to 180 now. Actually, we're doing maybe 3 and 4 a week almost at this point. So it's actually pretty busy. And this is when we had the Sapien 3 come in, actually out this far. This is again for 3-month data. Since then, we had done 17 cases from the groin and 1 case from the tip of the heart. So things have improved in that sense. So patients have quicker recovery. And what's more important, and this is we're really the only center that does this in the kind of near vicinity in the Los Angeles area, is that initially in the beginning we used to do all cases with general anesthesia, and in all cases we used to use transesophageal echocardiogram. That's the echocardiogram you do from within, really, when you swallow this probe and then kind of look at the heart from within. But currently how we're doing this is we're doing it with conscious sedation. So this is something that we use. We give fentanyl Versed, and then occasionally we can use some other kind of medications to kind of create sleepy state, I should say. But there's no general anesthesia, there's no breathing tube in most cases. And this helps us because it is more comfortable for you. There's no throat pain, there's quicker recovery. We get immediate neurologic feedback. Patients are more stable, so we're not having to deal with low blood pressures, high blood pressures, that type of thing. And then patients are going home a lot quicker. So again, like I mentioned, we're the only hospital that's really doing this in this setting. There's no breathing tube, so less risk of complications, so potentially less aspirations because that you don't have that breathing tube in. More patients are being done from the leg approach. And then in the beginning, before this, we instituted this moderate conscious sedation protocol. Patients used to stay in the hospital for 4 to 5 days. Now patients are staying in the hospital, usually going home the next day, in fact. But if there's something that we worry about, we keep them just to be safe another day. So our averages have been about 1.5 to 2 days lately. So things have improved dramatically from the first generation to second generation, especially at UCLA as well. So what do you really go through? Well, so there's before the procedure and after the procedure. So before the procedure, like we talked about in the beginning, you get an echocardiogram from the surface, and it's fairly straightforward. Less commonly, we ask for a transesophageal echocardiogram if there's something worrisome. This is really rare, but occasionally we use the transesophageal echocardiogram from the mouth. You end up getting a coronary angiogram, so it's possible that part of the chest pain and part of the shortness of breath could be from blockage in the blood vessel in the coronary. So we sometimes go in and we actually may end up needing a stenting of one of the blood vessels of the heart, which can be actually of tremendous help. You get an EKG. We do a CAT scan of the heart and abdomen and pelvis. This helps us pick the right size of the valve to put in, so there's no leakage around the valve, and we don't oversize it or undersize it. And this is how this really is impactful on how people feel afterwards, because the wrong size valve actually may create other problems in and of itself. And we haven't had any issues with that actually with sizing. So this CAT scan is very tremendously helpful. Carotid ultrasound, these are the blood vessels that go to the brain. That if there's a significant blockage there, that sometimes we need to talk to our colleagues in neurology and surgery to see if there's anything that needs to be done there, although we haven't had to do much in that sense either. Pulmonary function tests, we check the lung function studies, blood work, and ultimately we want clean teeth as much as possible because you don't want this new valve to get infected because it's a foreign body in there, and you don't, because if it gets infected, then it's a major problem to go through. Because of our diligence, we haven't had any cases of infection, in fact, with this new valve. So that's a good thing. What is the process? Well, you usually admit on the morning of the procedure. So you come into the kind of initial preparation area. So you get your IVs in, you come to the cath lab, we kind of give you the sedation medicine, we do the procedures. Procedure is done. It lasts about maybe 45 minutes to an hour in terms of us doing the procedure. Everything else kind of making you sleepy and kind of waking you up, maybe another hour on either end. It may be 2.5 hours sometimes at the most. And everything going well, you may end up going to a regular room after the recovery area, or you may end up staying in the ICU if there's something that we'd like to watch more closely. And then again, like we talked about, you can go home the next day or maybe the day after, unless there's anything new that's developing that we want to follow. So basically, surgery, and then this is where we put, this is somebody's finger. We just want to emphasize how small this hole is. You're going through this big a hole in the groin, really, to be able to put this valve up. So it's a pretty dramatic improvement in terms of where we've come and where we're going. Who are involved with these procedures? Well, this is one of the first cases, actually. There are many patients, many people in the room, many doctors in the room. This was one of the first kind of historic picture that we had in the beginning, but This is a lot less now. We have a slimmer crowd, but we still have 2 attendings at least in the room, usually 2 cardiac surgeons, 2 cardiologists in the room, myself and my colleague that I'll talk about. We have the echocardiographers, we're looking at the valve all the time. And then we have anesthesia attending who is giving the sedation, relaxation medicines. And then we have the cath lab nurses techs, and there's a device rep from company to help us out with the device procedure too. And that's where we are, really. So currently, the future is bright. In the aortic position, we have these valves available to us. This is the Edwards sapien valve, which is this one. This is the balloon expandable one. Medtronic core valve is the one that's the nitinol self-expanding frame. What's even better is that there are more valves coming up. And in the mitral valve position, which we touched on the mitral valve before, there's new valve development so that maybe in the future that we can use these valves to replace these valves without surgery also in the similar fashion. There's already a device called that we have at UCLA we're doing. It's called a mitral clip to treat the mitral regurgitation, which in patients who are not really candidates for surgery, it's something that can reduce the mitral regurgitation and actually will help improve the shortness of breath dramatically. That's one thing. And in the pulmonic position, that's the one valve that's going into the lungs. We already have, we've been using, actually, there's a valve called the Melody valve, and we also use the sapien valve in that position as well, and actually we did several in the past few weeks. So future is bright, and then things are getting less and less invasive, and we're very happy that we're able to offer these technologies here at UCLA as well. So these are just some of our patients. This is one of the earlier patients that was done. This is the next day, and this is one of our patients who was actually just maybe 2 hours after the procedure, and we were just kind of joking, chit-chatting about this. And this is myself, and this is my colleague, Dr. Sa, who's also my partner in this procedures as well. He's one of our interventional cardiologists. This is our team, myself, Dr. Sa, Dr. Urbani. We have a big team. On the surgical side, we have Dr. Shiman and Kwan and Banharash. On the imaging side, Dr. Vorobiev. Our valve coordinator, who's tremendously helpful to us, is Jeannie. She's really heart and soul of the program. On the anesthesia side, we have our specialist, Dr. Hoan Patel, and many nurse practitioners who will help transition from anywhere from pre-TAVR to post-TAVR side. And with that, I'll end. Again, this is my name. Any questions, here's my email, and this is the contact office number. So that's really it, okay? If you have any questions, we're open to them. Let me, now I'm going to look and see what's come through so far. So this is a quite interesting question. How does the cost of TAVR compare with surgery? So it depends on which cost you're talking about, really. To the patient, the cost doesn't change per se because the insurance, if the insurance covers it, if it's a high-risk procedure, most insurances cover this already. So to you, the out-of-pocket cost is not going to be any different. The one thing I will say is that surgery in terms of surgical valves are cheaper. So surgical valve is maybe on the order of anywhere from 5,000, somewhere in that ballpark, I believe. This TAVR valve ends up being actually 30,000, the valve in and of itself. But the patient himself or herself does not see that cost. It's something that that's incorporated that the insurance deals with. So it's not an issue. How should I change my diet if I have aortic stenosis? So that's a very good question. So if you think about it, the reason people get in trouble with aortic stenosis is that the blood cannot get out of the heart. It can go back into the lungs. So it's anything that will increase your blood pressure, anything that will increase kind of the water in the system, so to speak, may lead to more shortness of breath and symptoms of heart failure. And so eating things like salty foods, chips, canned soup, those types of things, in fact, may be detrimental and may put you in heart failure. And this is especially relevant now that we have the holidays coming up, so it's something to be watchful of. Next questions, are there any dangers to my pregnancy if I have aortic stenosis? So this is a very good question, in fact. It's rare that women of childbearing age will have significant aortic stenosis. Having said that, there are conditions. I mean, if you're born with a bicuspid valve, if you're born with some other kind of congenital anomaly, it's something that could be potentially dangerous, but it needs to be watched. Usually in younger patients, we don't really see this to be an issue because this calcific stenosis is usually what we deal with. Having said that, if somebody's born, if you're born with a kind of a congenital problem with the valve, it's something that you should really, really follow up closely with your cardiologist, because it's something that needs to be followed. What happens with pregnancy, if you have a severe valve disease, and we see this a lot of times with mitral stenosis, for instance, not aortic necessarily, but although aortic can be an issue, it's just that mitral stenosis in the childbearing age is a little more common due to rheumatic valve disease. Is that what happens with pregnancy is that you get more kind of fluid circulating, more blood circulating in the blood vessels, and that in fact can lead to heart failure, shortness of breath type symptoms. So it's something to be mindful of. It doesn't preclude somebody from getting pregnant, but that also depends on how severe the degree of aortic stenosis is. Something that really needs to be followed closely. Okay, so those were the 3 questions that we had. So this now concludes our presentation on aortic stenosis. If you have any questions at any point, please feel free to contact us at UCLA. We're always here. We're happy to help, and these are some of the email. You can always use the personal email. You can call the office to further discuss on the phone as well. Thank you very much, and hope this was helpful to you, and good luck. Thank you.